Hey guys, welcome back to another edition of the UK ICU curriculum. Today we're going to be talking about vasopressors. Just as a quick disclaimer, these talks are designed to be short summaries of these topics, kind of a 10-15 minute discussion. They're not designed to be a full expansive review. They're really hopefully supposed to complement some of the bedside learning that you're getting during this rotation. Without any further ado, let's get into it. Today the goals, as you can see, we're going to review the pharmacology and the action of some of these common vasopressors you'll see in the ICU, common indications for each vasopressor's use, review their safe practice, and we're going to review some common risks to the vasopressor use. Okay, when to use? Typically, pressors are used in shock to either augment cardiac output, we call it inotropy, or vascular tone, which is the resistance. Sometimes we call it SVR, systemic vascular resistance. Now, these are pressors. If we're going to talk about vasopressors, these are really should be used only after adequate fluid resuscitation has been achieved. And you can determine when someone is fluid resuscitated by several different techniques. You can use your physical exam, you can use CVPs and pulmonary capillary wedge pressures, although probably statistically they're not very good for that. You can use more dynamic methods like a passive leg raise or a fluid challenge. You can use IVC variability on ultrasound. You can use cardiac echo as well. So how are these pressors used? Typically they're used in continuous running IV drips, ideally through appropriate positioned central catheters to ensure their proper delivery and distribution. In some emergent situations, pressors can temporarily be used through peripheral IVs while you're getting central access. Although there is some risk to doing this, you can have extravasation of the pressors. That's where they leak out into the peripheral tissues. You can even cause peripheral limb ischemia. If you do it that way, you're going to need constant reevaluation, to make sure that in this critical period while you're getting central access that things are going okay. And really, if you're on pressors in general, you're going to need almost minute-to-minute monitoring. Okay. So the pharmacology. There are two, we'll say, receptor types that we commonly think about when we're dealing with pressors. That's the adrenergic and the dopaminergic receptors. This is just a little, cartoon that kind of gives you an idea on where these things lay. You can see here this stands for norepinephrine, and it's affecting the beta and alpha receptors in the heart and the blood vessels. Now we're also going to talk about dopaminergic. We're going to talk about dopaminergic receptors. These ones are on the renal vessels, but a little bit more about that later. So the two main receptors that we were talking about, we have adrenergic receptors with alpha 1, alpha 2. We have beta receptors with beta 1, beta 2, beta 3. Dopaminergic receptors, there's a bunch of different subtypes. You can see the ones here that are expressed on the blood vessels. And this is just a very quick, not super complicated mechanism of action. You can see here on the beta, you get heart muscle contraction when it's stimulated. You get smooth muscle relaxation. And for the alpha 1 and alpha 2, you basically get smooth muscle contraction. Now we haven't really talked much, but we will talk a little bit about this. I'm going to say a minor receptor type. And this is for vasopressin. There are several different receptors here, but the one that's probably most pertinent when we talk about shock or treating hypotension is the this V1A receptor, which is on the vasculature. We'll get into more of that in a little bit here. So who does what? You can see here, this is just a little quick summary. This is probably something that you should know about who does what. You can see that the alpha 1, alpha 2 are on the blood vessels, and they cause vasoconstriction. Beta 1 is located on the myocardium, and it causes inotropy, chronotropy. That's the heart beating stronger and faster. The beta 2 receptors are on the blood vessels, causing vasodilation. Now, we don't really talk about beta 3 that much because it's on adipose tissue, and that's not really pertinent to what we're talking about today. The D1 receptors are located in the kidneys, and they cause vasodilation. And then these V1 receptors are located on blood vessels, and they also cause some degree of vasoconstriction as well. So, pressor mechanism of action. We're going to focus on these. These are the kind of the big dogs that we're going to talk about today. You will probably see all of these used in the hospital at some point in time if you are an intern rounding and you have access to the ICU. And this is going to be the chart that we're going to kind of fill out so that we can kind of compare and contrast what do these do and help us get an idea on, okay, so if we know this does that, which ones do we choose for which problems? Let's talk about norepinephrine levophed first. This is going to be one of your mainstays in the ICU. This stimulates both alpha 1 and beta 1 receptors, causing both vasoconstriction of blood vessels and a little bit of increased inotropy and chronotropy as well. One of the potential side effects of norepinephrine use because of that beta-1 receptor stimulation is it can precipitate cardiac arrhythmias. So you might see AFib with RVR, you might see VTAC, and basically compared to all the other options, this is considered the first-line therapy for most types of shock, and particularly in septic shock. So this is, again, we're kind of filling out the chart here so you can kind of follow along to see what it does in relationship to the other pressors. Moving on to phenylephrine, or neosynephrine is the trade name. This stimulates only alpha-1 receptors, primarily causing increase in the systemic vascular resistance, the SVR. This is probably reserved to being an alternative to Levophed or norepinephrine when the patient develops those significant arrhythmias, or if you needed some sort of adjunct pressor, if what you were using wasn't cutting it. You can see here the only difference between phenylephrine and norepinephrine is now you've lost that beta-1 stimulation, so you only get this increase in SVR. Epinephrine. Epinephrine, or adrenaline, is a potent beta-1 stimulator, and you can see here it does have some dose-dependent alpha-1 and beta-2 receptor activity as well. So it causes increased heart rate, cardiac output, and a little bit of decreased vascular resistance initially. But as the dose increases, that kind of alpha-1 receptor stimulation really takes over, and you get a big-time increase in your SVR. So what you'll see here is you get this beta-1, beta-2 first, and then second effect, kind of as you increase the dose, is alpha-1. So you're going to get increased cardiac output, a little bit of decreased SVR at first, but then this takes over and you have an increase in your SVR. Dopamine. This is another pressor that has a little bit of a variable effect depending on what dose you use it. At low doses, the D1 stimulation causes a vasodilation of the renal bed. This is actually looked into quite a bit, and there's really been it doesn't sound like there's really been a clear benefit to this effect. There was at one point in time where people were using renally dosed dopamine, and that's not something that we do anymore. Then at medium doses, it stimulates the beta-1 receptors and predominantly causing increase in cardiac output. And at higher doses, it stimulates, again, the alpha-1 receptors and causes that increase in SVR. So you can see here, low dose, medium dose, high dose. Low dose, you get the D1. Medium dose, you're going to get a little bit more beta-1. And then at high dose, that alpha-1 really kicks in. All right, so vasopressin. Has lots of names, ADH, AVP, or arginine vasopressin. This acts at V1 receptors, causing vasoconstriction and an increase in SVR. Now, the other thing here, at really high doses, it decreases urine output by increasing water permeability and reabsorption. This pressor is typically not a first line. It is used only as an adjunct pressor. So, just something to know how it works. Probably should not be your go-to guy in the thick of it. And here we got dobutamine, sometimes referred to as Dobutrex. That's the trade name. This stimulates both beta-1 and beta-2 adrenergic receptors. So this is interesting because it causes both increased cardiac contractility and it increases cardiac output. But also, it's a vasodilator and afterload reducer. So it'll actually decrease your wedge pressure, as well. Because of this beta-1 stimulation, you're going to have arrhythmias and hypotension from the beta-2 stimulation, or its major adverse effects. And this is interesting. This drug is pretty much only used for cardiogenic shock. This is not really a pressor so much as it is an inotrope. So you really wouldn't use this as your first line for someone who's hypotense. More so, actually, the best patient would be someone who has a depressed ejection fraction or a low cardiac output and they're hypertense. And that patient, it's great because it's going to augment their cardiac output and maybe even lower their blood pressure with some afterload reduction as well. So you can see here it's got the beta-1, beta-2 effect, so it's going to increase cardiac output, decrease SVR, maybe lower your blood pressure a little bit. Okay, moving on to something a little different, we have milrinone here, or Primacor. So milrinone is a little different because it does not work on the same adrenergic receptors that we've been talking about this whole time. This is a PDE inhibitor. It decreases, the degradation of cyclic AMP. And what it actually causes is it causes inotropy by increasing the cardiac contractility and cardiac output, and then profound vasodilation, both of the systemic system as well as the pulmonary vasculature as well. This is not something that we routinely use in the pulmonary ICU, although we use it from time to time, and it's probably more you'll encounter it probably more commonly in the cardiac ICU for patients that have that real bad pulmonary hypertension. Again, because of these effects, as you can imagine, dysrhythmias and hypotension are going to be the major adverse effects. So let's compare these two inotropes that we've just talked about. We've got milrinone and we've got dobutamine. Dobutamine has more profound improvement in cardiac output, and it's metabolized in the liver and peripheral tissues, whereas milrinone really has more profound vasodilatory effects, and thus it's used more for cases of right heart failure from pulmonary hypertension, and it's also metabolized in the kidneys. Okay, so this is a quick general guideline summary of when you would want to use one pressor versus the other. So if you have someone who's in a distributive or maybe septic shock, norepinephrine or Levophed is definitely your first line pressor. You could consider changing to something else like phenylephrine if the patient develops a significant arrhythmia. And what we mean by significant arrhythmia is not just tachycardia. We mean some sort of probably life-threatening, arrhythmia. In someone who has cardiogenic shock, if you're hypotense already, actually a lot of guidelines recommend using Levophed and considering adding an inotrope if the patient is not hemodynamically stable with that pressor. If they have cardiogenic shock with hypertension, dobutamine and milrinone are both options. So these are the people that come in that are, have a bunch of edema, pulmonary edema, their blood pressure is like, 180, and they're kind of in hypertensive urgency or emergency. In that case, dobutamine might be better if the patient has renal failure, and milrinone could be better if the person has, pulmonary hypertension or right heart failure. Just something to think about. And then obviously if someone has anaphylaxis, epinephrine or adrenaline is the go-to guy there. That's pretty much it. Just a quick talk on pressors. Just something to kind of go over things for you guys, because you'll probably see all these out on the wards or in the unit as you're walking around. If you have any questions about this, you definitely want to ask your attending, and hopefully this will kind of complement some of the bedside learning that you're doing with him. All right, guys. Good luck out there.